Okay, cool. Sorry. Can you see my ID? I'm doing it from my phone. I don't. It's weird.
I cannot. Okay, now I can. Yes. Okay, that's good. And just show me your workspace. Good. Okay. Okay. Just kind of scan around your work area, please.
Good job. All right, Dana, let's just finish you up here. Your camera went off. Oh, computer issues.
Okay. Thank you, Kim. Sophie Wyland. Okay. I see your ID. Thank you.
This is my work area.
Okay. And your paper. Gotcha. Gotcha. Thank you, Shelby. Carrie Ann? It's Carrie Ann Williams. Oh. Carrie Ann, I'm sorry I left you in the waiting room.
It's okay. I know I was a bit late. My phone was a lot going on. Trying to get my
Okay. Well, you were in there, so you'll get your attendance for whatever time you were in there waiting. We're just now checking in. So do you have your ID?
I do. Hold on. I have to go
Okay.
get it. I don't have it with me. Is that okay? I'm sorry. I forgot about that.
I'll go ahead and check Michael in while you're getting your ID.
Okay.
Okay. Michael, do you have your ID? Okay. Thank you. Okay. Got your paper? Good.
Wait, no.
Look good?
You're good. Thank you. Okay, as soon as Kirian gets back, we'll get her checked in. I sent you a message giving you guidelines for today. After the exam, everyone should have plenty of time to finish and be back by 4:15. There she is. Hi. Okay. I'll look at your ID. Okay. And show me your workspace. Okay, good.
See?
And under your computer, please.
Don't put the camera.
Okay. And do you have stickers on your keyboard? Can I see that?
Yeah.
Okay. Okay, I just wanted to see what it was. And your paper.
All right, everybody, I'm going to share your map.
Okay. All right, thank you. We've got everyone checked in. We're ready to go.
Mrs. Falls, I can't promise I'll be back by 4:15 unless, yeah.
Okay. Well, you know how the attendance works. So whenever you check back in, you'll get attendance from that point on, and it's deducted in 15-minute increments. Okay. Okay. So our time to be back should be 4:15. When you complete your exam and you upload your exam to ExamSoft, you will see a green screen. So just be patient with me. Show me your green screen on Zoom, your Zoom on your phone, and I will message you to show you that all's good. You're free to go, and then be back at 4:15. Okay. Do you have questions?
I had a question. I know I've told people obviously don't call my phone during these times, but if it like pauses and I click on my phone to like swipe up a can we do that?
That's a
I don't
good
I
I
don't know.
would not, because you have to stay on camera.
Okay,
So
that's what I'm saying.
just-
Like I don't know how that works if somebody beeps in or something. So
If you have an iPhone, you can put your
Mhm.
phone on do not disturb, and that way you won't get any notifications.
and that'll stop, but it won't mess up the Zoom.
Yeah, it won't mess up the Zoom. It'll just stop you from like getting any calls or text messages to disturb you.
Okay. Let me see.
okay.
Okay.
Okay. So
And
once
Ms.
we
Falls,
start,
I'm sorry.
yes.
Can you repeat it one more time? After we get done, how does that work? What do we do?
You can go ahead and log out,
Okay.
and then just come back in at 4:15.
Oh, okay.
Fine. Okay.
Nunu, how do I put my phone on Do Not Disturb? Is that the same thing as putting it on silent?
No. Swipe down the right left corner. Here, I'm about to show you real fast. Show everybody if anybody else was wondering. But if you supposedly if you swipe down on the right side, it should be an option with a person on it. It'll say personal is the or do not disturb. Mine's I got customized one, so it say different stuff. But do not disturb should be the first one if you don't have none set up, and then that way you won't get any calls.
I love it how you guys share information. You're great.
Thank you.
Once we start,
Mhm.
we'll try to keep the classroom as quiet as possible, so everyone will be on mute. If you have an issue, you can message in chat, and I'll pull you into a breakout room. Okay. As long as you did the practice exam, your technology should be fine. Everybody have the exam downloaded? Yay. Cheyenne and Cheryl, I can't see you. You've gone off camera.
Am I back?
I can
Can you
hear
hear me?
you. I can't see you.
Oh my gosh, I was trying to mute my phone. I shouldn't have messed with it.
That's okay. We'll get you back on.
Am I back on?
I can hear you, but I can't see you.
That
Cheyenne, I
doesn't-
need to see you as well.
And you'll tell us the password so we can when we're
I
all
will.
done. Okay.
And I will read you the password, and then I will put it in the chat. So if you have any trouble getting in, it will appear in your chat.
Okay.
I sent you a personal message.
Okay.
Daggone it. I knew if I hadn't messed with my phone, I was all set. Hold on. Do I hit edit? No. Cancel. Oh, I see myself, but I'm just trying to add it to here. All right, let's go here. Let's go here. Oh,
Are you on the Zoom screen? Like, can you see us?
yeah, I see you guys.
So maybe down at the bottom left, is it a red mark on stop video
Hold
or
on.
video?
Hold on, I gotta go horizontal. Okay. Like I'm stuck in a screen. I see myself, but I can't. It's no red. It says backgrounds. I'm like stuck at the video filters.
Go to press. I just was doing that.
All right, I'm gonna go all the way.
Press in the bottom, the top left corner. It should be like a zoom out button.
Zoom out.
Dang, now I missed mine up.
Oh God, I'm so sorry. All right, here I go. I found it. Yay.
Oh, yay.
Sorry.
Okay.
All right, now let me get back to my horizontal. Okay. Do you need to see that again?
No, I know who you are. It's
Okay.
okay.
Thank you.
Yeah, I need to take care of one thing and then I will get you in. Just 1 second.
Can you mute me too?
I will. Yeah.
Thank you.
Okay, I'm taking care of one issue and then I will be right with you guys, okay? Okay, we're ready to start. So go ahead and mute yourselves. And Cheyenne, you can go ahead and make your decision now before I give the passcode.
Can you mute me, please?
Okay. Okay.
Oh, we don't get-
Okay, who am I muting?
Cheryl. Cheryl Juniper.
Okay, alrighty.
Sorry.
That's okay. Okay, Cheyenne, I need you on camera. Okay, your passcode for the exam is the number 3, capital P, lowercase j, lowercase s, lowercase n, capital Y, lowercase b as in boy, the number 9, capital E as in egg, capital Y, capital R, and lowercase t. And I will put it in the chat.
I couldn't get in. I got it wrong somewhere.
I'm putting it in chat now.
Are we okay to start?
Yes. Thank you.
Are you all set?
Yeah, we're good. I've got one with a migraine and one with strep throat that's bugging out.
So I had the volume down pretty low because for a while there was a lot of talking happening between all the classes, so they didn't hear you.
Oh, I've got one with a migraine and one with strep throat that are both bugging out.
Oh no,
Yeah.
that's rough.
Yeah.
Well, at some point we need to get together so that you can tell me all about your stuff. The
Oh,
nursing
yeah. It was really good. Probably the best OOPNIC conference I've been to in 20 years, which is saying a lot. I've
That's
sat through a lot
amazing.
of bad ones.
That's amazing. Well, have a good rest of your class. We'll have to
Alrighty.
find time to get on Zoom together later.
Yep. Thank you.
See ya.
Bye.
I made it.
Welcome back, everybody. Exam days are stressful, even if you know the material, right? Yeah.
I got stuck in traffic on the way back.
Oh no. Who said that?
I made it though. Me, Shelby.
Okay.
Yeah, I made it though.
Good. Good. Okay. We've lost a couple of sickly ones tonight. All right. Shelby Burton and Maggie Lomas. On my screen, you guys are lined up. You all kind of look alike. When you have your hair pulled back, when I'm sitting back at a distance, I can't always tell you all apart. Okay. We're going to do things a little bit differently tonight. I'm not going to go slide by slide. And someone had asked for PowerPoints early. So my PowerPoints now are all incorporated in the resources that you have. So you know how you get your, let's see, who's unmuted? I'm going to mute Shelby. Let's see. I think that's everybody. Okay. When you get your resources like weeks 1, 2, and 3, now 4, 5, and 6, all of my PowerPoints are in there. So you'll have those ahead of time. And you can go over those. And I know it's asking a lot for you to start reading and studying too much ahead on an exam week because you're really focused on the material from the weeks before for your exam. But it is important to, especially the weeks that you're not doing an exam, to jump in there and try to read ahead so you're prepared for the content that we're going to cover that week. Gonna make sure everybody gets back in here. So what we're going to do tonight, we just have an hour left, and I'm going to throw up the PowerPoints and we're going to hit a couple of the important slides. And I've kind of mapped out what I'd like to do. And what I'd like to do is talk about our content for this week is assessment, essentially. So we're going to talk about important assessment. We're going to hit a few slides, and then we're going to do about 4 case study kinds of questions. and talk through those. So I'm going to share my screen. Oops, we got a message here. Oh, someone asked about how many minutes you're allowed to miss. Ultimately, it really doesn't matter along the way, but ultimately in the whole course, you're allowed to miss up to 20%. And then after 20% of course content that you miss, they deduct a letter grade. Now, if you miss 2 consecutive weeks, you are withdrawn from the program, but that means 2 consecutive class days. So if you miss one entire class and then you miss the next class, that's 14 days in a row. Even though that you're in there working on assignments and things, it's live classroom time, 14 days in a row. So they will withdraw you from the class. So be sure that you don't miss 2 classes in a row. That's very, very important. I try to monitor that too, that if you've missed one day, if something happens in life, last term we had someone who had a car accident and then had a doctor's appointment the following week. And I was new to Fortis, so I didn't think about that. They, often if you have something that happens, they schedule an appointment exactly a week later. Well, that was unfortunate because we had to work that out with the dean. So just keep in mind that you can't miss 2 consecutive weeks, okay, because that will withdraw you. But as far as attendance goes, 10 minutes here, 10 minutes there is not a big deal until you max out at 20%, and then that drops you a letter grade. Okay. Of course, my PowerPoint is not up. Everything else but that. Okay, can you see my PowerPoint now?
Yes.
Okay, great. Okay, again, we're going to talk about mostly postpartum assessment and complications, but again, I'm going to flip through slides pretty quickly. The first question, actually, I'm going to go to the very end. I've got a couple questions here for you that it's not actually postpartum. It is during labor that we need to talk about. So let's talk about this question first. So you've got a 24-year-old woman who is 34 weeks gestation. She's been admitted with severe preeclampsia. She's receiving an IV infusion of magnesium sulfate for seizures and to prevent seizures. As the nurse, you know it is critical to monitor for signs and symptoms of magnesium toxicity and assess the patient carefully. Okay. Go ahead and unmute yourselves because I want you to talk with me. Everyone unmute.
Bless you.
Okay. Why is the primary reason that we use magnesium sulfate? Priority.
Prevent seizures.
Prevent seizures. What else does it do? Like when you have a patient who is preeclamptic, what are some of the things that we see that symptoms of preeclampsia?
Glucose levels.
Blood pressure.
High blood
Hypertension.
pressure, yes, very high blood pressure, and headaches, right? Those are some of our big symptoms. Swelling, big symptom. And it does reduce that blood pressure. And a lot of people have the misconception that we give magnesium sulfate to bring the blood pressure down. And it does do that. But the priority reason for giving it is to produce or prevent seizure activity. So be sure that you remember that it's not to bring the blood pressure down, which is a very concerning problem with preeclampsia, because it can be very, very high, stroke kind of high. But the reason we give it is to prevent the seizures. Okay, so when we're looking at prioritizing things that we're assessing the patient for, and we want to select all that apply. So what things are we assessing here?
Deep tendon reflex.
What do you expect to see as a result of giving magnesium sulfate?
Cramps.
No, not cramps. Actually,
Relaxing of the tendons, the muscles.
yeah, actually you see the opposite of cramps. You see the deep tendons relaxing. So when you assess for their reflexes, they're no longer hyperreflexic. You see lack of reflexes. Okay, so what's that going to do to their respiratory rate if their reflexes are relaxing? What do you see happen with
bradycardia or below respiratory?
Yeah, the respiratory rate decreases. The diaphragm's not functioning as well, and the respiratory rate decreases. Okay. What do you see with the urinary output?
Decreases.
It decreases.
It decreases.
It decreases, yes, because the kidneys aren't being perfused as well. Okay, so we see deep tendon reflexes. If they're preeclamptic, you expect them to be hyperreflexic, right? That's what you see with preeclampsia. But if they're becoming oversaturated with magnesium, and that's what we're looking for when we're doing all this monitoring, then they're going to be hyporeflexic. Their reflexes are going to be diminished. So we're looking at, and if it's asking what we're monitoring for, deep tendon reflexes. So are they still hyperreflexic? Because if they are, then we may not be reaching therapeutic levels with the magnesium yet. So we need to keep it running. Okay. But if they're diminished and we can hardly get a reflex out of them, then we need to be watching, because they may be getting toxic or reaching toxic levels of magnesium. Urine output, they need to be having at least 30 milliliters of urine per hour. Okay. Because the urine output will decrease. So we need to be watching how much urine they're putting out per hour. So we're doing hourly urine checks. Respiratory rate. What should the respiratory rate be?
Like what's its normal range?
Yeah. 12 to 20.
12 to 20.
Yeah. If 12 to 20 is normal, we don't want it to drop below 12, do we?
Nope.
No.
And we know that magnesium is going to lower it. So we're going to expect it to be dropping lower. That's expected. And that would be normal for that patient, but we don't want it to drop below 12. So we're going to be monitoring it. If they're 12 or 14, are they therapeutic? Probably, because that's what the medicine's going to do. And that's what we're going to expect to happen, but we don't want them to be 8. We're going to be very concerned if they have 8 breaths a minute. So we expect them to be the lower end of normal. That means their medication is therapeutic. What about blood glucose levels? Does it do anything to their blood glucose levels?
Shouldn't, no.
No, shouldn't. No. So if we're going to select all that apply, we're going to select deep tendon reflexes, urinary output, and respiratory rate, right? Have any questions about those?
No.
Okay.
No, ma'am.
Let's see. Okay. That one really is our only question I have during labor. Something else that you might assess during labor would be when you do your epidural. What are you going to be assessing after you put the epidural in?
Blood pressure?
Okay. Blood pressure. What happens with the blood pressure after an epidural is placed?
Goes down.
It goes down. What happens when mom's blood pressure goes down?
Babies go down.
Goes up.
Heart rate.
Baby, yeah, baby's heart rate goes down, doesn't it? So you want to monitor that closely. What are other things that we're monitoring or assessing during labor?
Urine out.
Heart rhythm.
Baby's heart rate. We're monitoring contractions and assessing what the baby's heart rate does during contractions too, right? Okay. So all of those assessment skills follow us from labor and delivery, whether it's monitoring mom or monitoring mom and baby, right on into the postpartum period. So that's where we are today. So you can read through the slides. So we're not going to have time to go slide by slide, but the more important things that we're assessing at the bedside are going to be things like, I think I skipped right over the breasts. Here we go. Breast assessment, we're going to be looking to see, is mom getting engorged? Does she have colostrum still? Is her breast milk coming in? Are her nipples getting cracked? Does she have blisters? Those kinds of things are telling us that if the baby's latching on well. If it's not latching on well, we need to be assessing her while she's breastfeeding and seeing if we can help her get that baby onto the breast more appropriately so she's not having those kinds of issues. There's things that we can do that will help that. If she's getting engorged, we want to make sure that if she's breastfeeding, she might be pumping more, breastfeeding more, expressing that breast milk will help with the engorgement. Now, if she's bottle feeding, we don't want to encourage the breast milk to be expressed because although it will give her temporary relief, that will encourage more breast milk to be made and will only intensify the problem. So if mom's not breastfeeding, when she's in the shower, she wants the hot water to hit her back because the warm water will encourage milk to be released and her body doesn't know that the baby's not eating that milk and she should not make more. So although a hot shower and releasing that milk will make her feel better if she's engorged, it will in turn make things worse because it will have her creating more breast milk, which is not going to be in her best interest in the long run. Okay, Amber, are you able to hear now? You said you were having trouble.
Yes, I can hear.
Okay. Let's see. Okay, now we're going to talk about some assessment of the uterus, and depends on how the baby comes out. Is it a vaginal delivery? Is that a cesarean delivery? As to how aggressive you can be with your massage, but either way, you need to massage that fundus of the uterus to make sure that it's firm. Firm and boggy are two words that we use to describe what we're feeling. Firm feels like an apple, or maybe we should say a pear because the uterus is more pear shaped, but it feels like a hard piece of fruit when you put your hand on it and feel it. If it is firm. If it's boggy, it feels mushy, like a maybe like a rotten piece of fruit, or an overly ripe piece of, like an overly ripe banana would feel mushy. So you're going to put one hand to support the uterus so you don't push it too hard, because it can be pushed out of the abdominal cavity through the vagina. So you want to support the uterus there with your usually your non-dominant hand, and massage with your dominant hand. But you want to feel it to make sure that it's nice and firm. Massaging it causes the uterus to contract, and the contraction of the uterus will decrease the bleeding. Also, the baby nursing causes oxytocin to be produced, and that causes the uterus to contract, and that causes less bleeding, or leads to less bleeding. So regardless of how mom delivers the baby, if she has an incision line there, you can see in this picture, there is an incision. I think you can see my pointer. You would see the incision line here, and you would still support the abdomen and massage the fundus of the uterus. What you would expect a couple hours after delivery, regardless of whether it's a vaginal delivery or C-section, the uterus should be just barely above the umbilicus. Not a lot, just if you start massaging right there around the umbilicus, you should feel it right in that area. If you're massaging a couple hours after, and you can put a couple fingers above the umbilicus between your hand and the uterus, that's too high. Okay, it should be right at that level. And if you find the uterus like pushed to the side one way or the other, it's usually because the bladder's full and it's not allowing the uterus to contract and fall back down into the pelvic cavity. So the first thing that we're going to do is empty that bladder. Now, ideally, we would either help mom to the bathroom or help her onto a bedpan, let her empty her bladder. If she's still very numb from an epidural, we might have to straight cath her. But the most important thing is that we slow the bleeding down if she's bleeding, and firm that fundus up to prevent further bleeding. So we need to get that bladder emptied. That's going to be our first priority in order to get that fundus firm, get it back midline and below the umbilicus. Okay, that's going to take care of a multitude of problems. If we don't do that, if she's not bleeding yet, she will be. Okay, so we need to do that first, and then frequently reassess her bleeding and her fundus. I would assess it every 15 minutes. If I find a patient that her uterus is above the umbilicus and shifted to the side, I would first thing cath her, or let her try to void, but then cath her if she couldn't, because we want to make sure that there is the bladder is empty and we get that back to midline and get it firm, because we're asking for trouble if we cannot get that under control. Okay, this is just a little diagram that shows you each postpartum day, the uterus should go down by a finger or two below the umbilicus until it gets back to a pre-pregnancy state. Okay, questions about assessing the uterus. Okay, now we're going to talk about bleeding, and probably this would be your biggest assessment skill, your most important assessment skill, because that's where your main concern is going to be. Your most life-threatening issue would come up with postpartum bleeding and hemorrhage. We're going to skip through a lot of these slides. Lochia is what you call postpartum bleeding, and if it's red, we call it rubra lochia. If it's kind of pink as it starts to dwindle, the next day 2, day 3, as it changes from that bright red bleeding to a pinkish discharge, we call that serosa. And then a few days later, a week or so later, as it changes colors and it turns to be that clear or whitish discharge, then we call that alba. So you can see what amounts on a pad would look like. We would document that it would be scant if it's just like a little smear. If it's just a little bit on the pad, we're going to say light. If you have about a half a pad saturated, we're going to call that moderate. And if the entire pad is saturated, we're going to call that heavy. Now, if they're saturating a pad every 15 minutes, that's heavy bleeding, and that's too much, even right after a delivery. Your first time that you change pads after a delivery, you might have the pads saturated, but it may not all be blood. It may be amniotic fluid and blood, so you don't know that it's all active bleeding. That first time you change those pads, you really don't know how much of that is bleeding. Okay, here's a picture of what like a breast infection could look like, how it's red and kind of splotchy. Flip through these really quickly. You can go back, you'll have access to them. I will post these along with you already have access to them in that resource page I told you about, but I will also post it with a recording from today. Okay, let's talk about postpartum hemorrhage and bleeding. So if we've got a patient who is bleeding and we didn't catch it quick enough, we didn't realize that the fundus was boggy and it wasn't staying firm, and we walk in and we see a patient like this, we're going to have to intervene. Okay, when we want to catch it is when we're seeing symptoms of shock, or we want to catch it before we get to this point, is what I'm saying. A vaginal delivery, blood loss should be 500 milliliters or less. Anything over 500 milliliters would be considered a hemorrhage for a vaginal delivery. Anything over 1,000 for a cesarean section or surgery would be considered a hemorrhage. Okay.
I have a pretty disgusting story about hemorrhaging.
Okay. Tell us your story.
I had my son. I had placenta previa anyways with my pregnancy. And but everything was healthy, everything was good. He was a full-term baby. But when I gave birth, I have to have C-sections because my uterus is tilted and I can't dilate.
Okay.
So I've had scheduled C-sections, and he was my second one, and everything was great. Delivery was great. But a few hours after delivery, they came in to massage my fundus or whatever.
Yeah.
And I remember like coming, like I couldn't stay awake at all. Like I couldn't wake up. And I remember they hollered for the nurse and they pulled a code blue, and my doctor, my actual surgeon doctor, my OB/GYN came running in, and I remember asking her, I said, am I going to die? And she's like, not on my watch. And I passed out. And my mom said that she went in fist all the way down to her elbow or up to her elbow, and she pulled out a blood clot the size of her fist. It was disgusting.
And yeah. And what happens is once that blood starts to accumulate inside and form a clot, it keeps the uterus from clamping down and those blood vessels sealing off. So you just continue to bleed out. So you have to remove that clot, however you have to do it. Sometimes you can massage and it will come out. Sometimes you have to go in and retrieve it and pull it out, but it has to come out. Yeah. Yes, that happens. And we want to intervene back at the point that we realize that the fundus isn't shrinking down, it's not getting firm, before you have a clot stuck in there that you have to go get. Yeah. Cheyenne, did you have a question? I thought I saw it pop up and then I couldn't find it. Or someone had a question. What causes hemorrhage? Is there anything to prevent it or to increase the risk? There are things that increase the risk. Big babies increase your risk. Preterm babies increase your risk. If the placenta doesn't come out smoothly, or there's a fragment of it that's left inside, then that increases the risk. So there are things that will cause it to happen. But the easiest thing that we can do to prevent it is be diligent about massaging. There are moms that, you know, after I've massaged them a couple times, and it's like you massage and the uterus gets firm. And this happens especially with a big baby. You know, they've delivered a 9.5-pound baby, and that uterus is just having a hard time. And maybe it's baby number 4, you know, so their uterus is having a hard time reducing and staying back down to the appropriate size. So I massage their uterus, and it contracts back down. I go back in 10 minutes later, and it's starting to get boggy again and not as nice and firm as it was the last time I massaged it. So I massage it again, get it nice and firm again. And I tell mom, you know what? Your uterus isn't staying as firm as I like it to. Why don't you just lay there and massage it for me? And that sounds bad, but if she's laying there in the bed, she can kind of rub her stomach. Okay. And that will help. The other thing that helps tremendously, probably better than anything else that we can do, is let that baby nurse. Okay. If there's not any other reason that she cannot nurse her baby, the baby nursing releases oxytocin. The oxytocin causes the uterus to contract. I mean, we can give medications in the IV that cause it to contract, but that is nature's way. So her breastfeeding the baby and the oxytocin that she's producing naturally will cause the uterus to contract. And that's probably the very best thing that we can do. So the whole skin to skin and the breastfeeding right from the very beginning is probably the best thing that we can do to prevent postpartum hemorrhages. Does that answer your questions? Okay. Okay. Let me hop back to our slides. Okay. Other things that will cause some hemorrhages that you will see will be lacerations, and those usually you can see. So if you have a postpartum laceration or a hematoma, you would apply ice to a hematoma, and you would be assessing that. A patient can't always tell you, they can't always see. They may say it hurts, but they can't always see what's going on. So you're going to be assessing for a hematoma. So you can't go in and just massage their fundus. You got to look at their bottom too. If they had a vaginal delivery, you need to be looking at their bottom every time you massage their fundus, because you don't know if there could be a hematoma there that you're unaware of. And you don't want it to get to this point and you not know that it's there. So that's something else that we're assessing for. Okay. Medications that we use to prevent uterine atony. And these are the drugs. When you say, what do we do to prevent the bleeding? These are the things that we do pharmacologically. So oxytocin is the same as Pitocin. That's a medication that we put in their IV. And Cytotec is a medication that's used rectally. Methergin is a medication that we use. It's given IM. At one point, many years ago, they did use an IV, but we realized that it can cause a stroke. So absolutely IM only. Pitocin is IV. Methergin is IM only. Pitocin you can do IM as well. So Pitocin is IV or IM. Again, Methergin is IM only, and it's contraindicated with hypertension. So when you think about these drugs and you're trying to remember them and you're studying, remember Pitocin is has less contraindications or less restrictions maybe on them. Methergin is the one that you have to be more careful with because it can only be given IM and you can't give it with anyone with hypertension. So this is the one you have to be more careful with. Prostaglandin is the one that we use is Hemobate, and it's contraindicated with anyone with asthma, and it's given IM and it's given every 15 minutes as long as they're bleeding. So Hemobate, and it's a prostaglandin that we use. So these are your primary drugs that are given for bleeding. Okay. Pitocin is given after every delivery. I don't know any place that doesn't just give that routinely. After the placenta is out, we go ahead and give Pitocin. So that's a drug that's given almost after every single delivery to help the uterus contract and prevent the bleeding. Okay, here's our little help sign. So these are signs of hypovolemic shock. And when we had the picture of the person in the bed with the blood all around them, we don't want to walk into that. We want to catch hypovolemic shock before it ever gets there. When we start recognizing signs and symptoms, we want to recognize that our patient is bleeding too much. When we start seeing signs of tachycardia, when the heart rate is starting to increase a little bit, and we start seeing some signs of hypotension, heart rate's going up, blood pressure is starting to fall, maybe they're even starting to look pale. You know, we would really like to catch it when they're starting to get tacky. With that first signs of tachycardia is when we'd like to catch it. We don't want them to be pale by the time that we're recognizing it. Their skin will get cold and clammy. And who was it that was telling us about their experience? I can't remember who was telling us, who gave us their experience.
It was Shelby Burton.
Okay, Shelby, when you said you couldn't think and you ended up passing out, those mental status changes, they're really foggy. They may not be able to communicate, or they're not communicating clearly. We don't want to get there either.
Yeah, I don't remember probably the first 3 days of his life.
Yeah.
No clue.
We don't want to ever let it get to that point. We want to catch it with these very subtle changes at the beginning before we ever get to that point. And then when you start not perfusing the kidney, then you have decreased urinary output, and you can have kidney failure. You can have actual damage to the kidney that may or may not be repairable. So we don't want it to get to these latter stages. We want to notice that, gee, her heart rate's climbing and her blood pressure is dropping a little bit. Let's explore what's going on here. So these are our signs of hypovolemic shock. Let's scroll down here and see if we find another question.
Can I ask a quick question before we move forward?
Absolutely. Yes.
So when you were talking about the Pitocin, and you mentioned that usually, well, everybody gets it to deliver the placenta. Is that even if the mom is not being induced prior to having the baby?
Yes. And it's after delivery of the placenta. You don't want to give Pitocin while the placenta is still inside because it can trap it. Okay. Because it's going to cause that uterus to clamp down, and you want the placenta out before it clamps down. But yeah, if most everyone has an IV now for delivery, even if you don't have an induction, even if you don't have an epidural, most people, maybe if you were delivering at a birthing center with a midwife, I don't know if they would let you deliver without an IV, because it's really important to have an access line. You know, maybe it would be a saline lock, okay, in the most non-interventional circumstances, but you want some kind of a line in place in case a patient would hemorrhage. Okay.
Okay, got it. Thank you.
Oh, you're welcome. But once that placenta is out, then we go ahead and give Pitocin into a port of some sort, usually because it acts more quickly that way, and or into the IV line. If it's already in your IV, say you had an induction and you already have a bag of Pitocin hanging and it's just been dripping in slowly, we might just open it up and let it run in at a faster rate, and that will cause the contraction of the uterus to slow down the bleeding. But yeah, pretty much everyone gets it. Okay. Okay, here's another question. A 29-year-old patient is 2 hours postpartum after spontaneous vaginal delivery. The nurse notes that the patient is saturating a peripad. Every 15 minutes upon assessment, the uterus is palpated above the umbilicus and deviated to the right. Which action should the nurse take first? Massage the fundus firmly until it is firm and centered. Notify the healthcare provider immediately. Encourage the patient to empty her bladder. Administer IV oxytocin as ordered.
Empty the bladder.
Empty bladder.
Empty the bladder.
Yeah. What about the other things? Massage the fundus firmly until it's firm and centered. Are we going to do that?
No.
I mean, we could try, but it's not gonna stay.
Yeah. We've been doing that probably, and we're going to continue to do that. But what we need to do first, right now, is empty her bladder, isn't it? Probably not something we're going to notify the healthcare provider about. Not now. You know, if we can't resolve it, we would, right? And administer IV oxytocin as ordered. We've probably already administered it prior to the 2 hours. And that's not really a standing order to use repeatedly. So you wouldn't really know that unless you practiced in OB, but that's really not an appropriate order at this time. Okay, good. Okay. A 28-year-old mother who delivered vaginally 2 hours ago is experiencing a postpartum hemorrhage. As the mother, or as the nurse caring for her, you are monitoring signs and symptoms of hypovolemic shock. Select all that apply. Which of the following assessment findings are signs of hypovolemic shock? Tachycardia?
Yes.
Yes. Hypertension?
Yes. No.
No. It's hypo, isn't it?
Yes. Low.
Yeah, low. Hypo. Pale, cool, clammy skin?
Yes.
Yes. Increased urine output?
No.
No. It decreases, right?
Yes.
Yeah. Decreased blood pressure?
Correct.
Yes.
Yes. Yes. Relentless. Oh, I'm sorry. I can't read from a distance. Restlessness or anxiety?
Yes.
Yeah. Yeah. That goes along with hemorrhage and when a patient bleeds out. Bounding peripheral pulses?
Yes.
What happens to your pulses when you bleed out?
They're probably weaker.
Yeah, they get weak
No.
and thready. Yeah.
Bound.
Yeah. They're not bounding. Yeah. Bounding would be if you had like your blood pressure was going up and you had a lot of blood volume in there, you would have bounding pulses. Okay, good. And when you think about, I'm not sure where you are, and I know everyone is not exactly in the same place in their curriculum always, but when you think about hypovolemic shock in a pregnant patient, you really don't treat them any differently, or you don't think about them any differently as any other med-surg patient who's bleeding out. The symptoms are all the same. Okay. Tachycardia, hypotension, the pale, clammy, cool skin, decreased urine output, decreased blood pressure, the restless anxiety, the thready, weak pulses. All of that is exactly the same as your med-surg patient, because when you bleed out, it doesn't matter that you just had a baby. You're the same as every other hemorrhaging patient that's going into shock. Okay. So don't try to make them any different. They look exactly the same. Okay. Let's jump back up here where we left off and hit the last few important pieces before I let you go today. Okay, DIC, it's disseminated intravascular coagulation. And what happens with DIC? Patients who are hemorrhaging use up all of their coagulation, their clotting factors in their blood, and they bleed out from everywhere. Okay, so it happens in obstetric patients. It happens in trauma patients. So again, this isn't isolated to obstetric patients by any means, but you need to know that that is a complication that can happen. What you see in these patients is, since they've used up all of their clotting factors, they bleed from everywhere. Okay, and you can't stop it. It's like an overcorrection of the body that the body tries to make, and then once it's overcorrected and it's used up all of its clotting factors, there's nothing left to clot. So these patients, they bleed from all over. You will see patients who bleed from their IV sites. They will bleed, they'll have petechiae from being touched. They will have like petechiae from the blood pressure cuff, not from it being like necessarily too tight, just from it being pumped up on their arm. So they just bleed out. And this is a true emergency. These patients, I don't know a percentage, but many of these patients die. We give them clotting factors, a blood product of clotting factors, but truly this is a life-threatening situation, and many of these patients die once they go into DIC. I think I have one more question for you. Okay. You have a 32-year-old mom who's 12 hours postpartum, and she had a vaginal delivery. She's thirsty and kind of weak. She's showing on her vital signs a temperature of 100.6. Her heart rate is 102. Her blood pressure is 110/70. Respirations are 18. Her oxygen saturation is 98%. When you're looking at those, you're thinking dehydration. And the question is, which of the following assessment findings or factors support the nurse's suspicion of postpartum dehydration?
Dry mucous membrane.
B, A, C,
Okay, A and C.
D. Can be tacky.
Yes, A, C, D.
F.
F.
And etc. Yes, that's correct. When you see an elevated temperature in a postpartum patient, especially if it's a cesarean patient, we monitor that closely. 12 hours is a little early for someone to be showing up an infection. Okay. However, if you have a patient, even a vaginal delivery, can have an infection. What we're looking at is the time frame. If they've had a baby, you're looking at 24 hours plus for them to start getting infected. So 12 hours is a little early for the infection. But also patients who have labored for a long time, maybe they've labored for 12 to 24 hours or even longer and not really had a lot to eat and drink in that period of time. Those patients are very dehydrated. Dehydration causes your temperature to go up. Okay, so those elevated temperatures in the first few hours after the birth of a baby, we often attribute to dehydration. Even if they don't have the dry mucous membranes and poor skin turgor, we're still looking at what's been going on with this patient, if the elevated temperature is all you're seeing. So look at the other things that are going on with them. This case study is very pointed at dehydration, with the heart rate being up. That tachycardia is indicative of dehydration, but it can also be indicative of an infection. If they have a fever, the heart rate goes up and they're infected. So those things all go together as well. But with dehydration, your blood pressure goes down. Okay, so this is very pointed towards dehydration, but always look at your time frame after delivery as to, could it be long enough for them to actually be infected yet? And how long have they been in labor? So when you're looking for infection and elevated temperatures, take all those things into consideration, because those are very important aspects as well. And if you're looking at dehydration, look at your urine output. Again, important factors. Okay, again, I'm going to post your PowerPoints. Let's see what all you got coming up this week. This week we took our first exam, and you have a CJ Sim due, and your second discussion is due. Be sure you get your initial discussion post in by Wednesday. Most everybody did really well about that. And do your in-text citation so you get all your points. And be sure that when you're responding to your peers that you don't just say, yay, you, good job, or I agree, because you want to add substance to their thread to make sure that you get all of the points available. There's a rubric that we use to grade, and you have to be attributing something of significance to your peer's thread in order to get your points for that. So if you're unclear on that, be sure you read the criteria so you get all your points. That makes a difference in your grade at the end of the term. CJ Sims, you can do those again as many times as you want to get all the points. So if you scored a 83 on it, that only gets you 80 points. Do it another time or two, at least until you get over that. I think it's 89 or something gets you 80 points, but a 90 or above gets you 100. So you want to repeat that in order to get your 100 points. So that's what you got going on this week. And coming up next week, is just chapters 11 and 12. So that's not quite as much reading as what you've been doing. And you have a quiz next week in class, and you'll have OB math due next week and another CJ Sim. So moving right along. I can't believe that we're already this many weeks in. Do you guys have questions?
I have a question, but it's not pertaining to my first discussion post. I know you were saying that you would give points back, but I never did get points back.
Points back for the introduction?
Yes, ma'am.
Or, okay, was it because you were, I can't remember.
I responded to two of my peers, but apparently I didn't get the points back.
Okay, who's talking? I can't find you.
Courtney Nelson.
Okay, I'll have to go in and I'll have to go look, okay?
Yes, ma'am.
Check on that. Okay, any other questions? All right, we will do an items analysis on Friday night. That will be no going out to the movies on Friday night for us. We'll be doing test reviews, and then hopefully grades will be released Friday night, so you'll know what you got. Again, I think we talked about last week. Worst case scenario, if there's any discrepancies or students who haven't had a chance to take yet, it could be as late as Saturday morning, but hopefully you'll see your grades pop up on Friday night. If you have any issues, concerns, reach out to me. You know how to find me. And if I don't respond within a reasonable amount of time, you go ahead and text me again, okay?
So do you guys normally end up giving like significant points back?
Not usually. I mean, I was just here last term and there was probably, I don't know, a half dozen questions through all of the exams that maybe they gave two answers, credit for two answers, or throughout one question, maybe something like that. But it wasn't much. The questions that are in our question bank have been used for probably years. I don't know how long they've been using them, but after each exam, all the instructors get together and we review what all the students do on those questions. And if there's something that is questionable, or a lot of students miss one question because there's two answers that are very similar, they note that, and then they go in and they rewrite that question or take out the distractor that's confusing and put another distractor in that's very different. So the next cohort of students who that question's available to, the question should be corrected. So that really eliminates those confusing questions and makes the test bank that we choose from much, much better. So there's the questions that I saw were really good. And they just keep getting better and better. So there's not too many and students never really even know, it's been corrected before the grades are released. So if there's two answers that a lot of students had trouble choosing between two, and then we look at it and the question's worded in a way that it's like, well, yeah, we understand why they chose those two particular answers. And then they decide, not just one class, but all cohorts get credit for A and C. It's all done before the grades are released. Does that make sense?
Yeah.
Okay. All right. Well, take you a deep breath and relax tonight. Your first exam's behind you, and get ready to jump in there and start moving towards exam 2. Quiz next week. All right. And those of you who are rushing off to get to your destination for your exam and all that, try to relax. You made it. I know it was stressful for some of you. Have a good week.
You too. Thank you.
All righty. Bye-bye.
Have a good one. Bye.
Bye. You okay, Cheyenne? I know it was a tough one for you.
Yeah, I had gotten off work this morning and I was laying in my bed listening to all the lectures and the study references that you've given us. And I'm